And that's the video or not. Yeah, okay. I think it should be okay.
Should be all right.
Okay. Okay, thank you.
Sorry about that.
Alright, sorry everyone, there's a bit of delay, technical issues. So first of all, thanks to Brett and Colin for giving this opportunity to talk about this very informative day, and thanks to everyone for coming here on your busy weekend. So already, I think Brett has already informed. So I have a special interest in cardiac MRI, and as a pediatric cardiologist, that's something I'm quite passionate about. So I have no disclosures. So no talk is complete without talking about Dr. Noonan, and I'm quite fascinated because obviously she's pediatric cardiologist. So I just run this couple of minutes short video. I'm pretty sure most of you do know about Dr. Noonan, but someone, if you're not aware, then just a little bit of summary about who Dr. Noonan is and what she did for the field of pediatric cardiology.
Dr. Jacqueline Noonan has been caring for children with heart disease for over 50 years. During a time when there were few women doctors, Dr. Noonan emerged as one of the first female pediatric cardiologists. She observed that children with a rare heart defect often had a characteristic physical appearance with short stature, webbed neck, wide-spaced eyes, and low-set ears. She first described the syndrome in 1962, and subsequently it became known as Noonan's syndrome. In recent years, the genetic defects that cause Noonan syndrome have been established, and with it, the ability to test, provide early intervention, and eventually to find a cure. Her groundbreaking work in pediatric cardiology has helped tens of thousands of children and their families throughout the world. Although technically she has retired from her position at the University of Kentucky, she continues to teach, write, and see children with heart problems in clinics throughout eastern Kentucky. Dr. Noonan considers the love she has received from her numerous patients to be her greatest honor. The Castle Connolly 2008 National Physician of the Year Award for Lifetime Achievement, Dr. Jacqueline Noonan.
What a remarkable doctor and what a remarkable career. So talking about the cardiac involvement, so as we all know that the incidence of Noonan syndrome is somewhere between 1 in 1,000 to 1,500. And the cardiac involvement is one of the main clinical features of Noonan syndrome, and something which is quite concerning as we investigate kids for. The prevalence of cardiovascular abnormality is nearly 70 to 80% of cases, depending on the series we look for. However, on the positive side, 20% of them doesn't have a cardiac lesion. So the Noonan syndrome doesn't make you have to have a cardiac lesion. You could have a completely normal heart for entire life. So we know that there are a lot of genes involved, and there are some of the common genes involved in Noonan syndrome, and something particularly interest for the cardiologist are the PTP-11, RF1, and MAC1 and 2 genes. They are associated more commonly with cardiac lesion than rest of the genes. Now the cardiac lesion which are common in children with Noonan syndrome is pulmonary stenosis is the most common lesion. It's present in nearly 50 to 60% of all the kids with the heart disease. The second commonest is the hypertrophic cardiomyopathy, in which the muscle of the heart becomes quite thick, and they can cause a dysfunction. Again, the hypertrophic cardiomyopathy is usually detected early in the life, mostly in the first year of the life, and if it's diagnosed at that time, that's the time when it's most concerning. Other lesions include atrial septal defect, which can present up to 10% of the cases. So these are the 3 most common lesions present in the kids with the heart disease. There are other cardiac lesions associated with it, but they are not that common. So it could be a ventricular septal defect, it could be a pulmonary artery branch pulmonary stenosis. We can have anomaly in mitral valve or coronary arteries, and the less common are coarctation of aorta, tetralogy of Fallot, and patent ductus arteriosus. And I'll talk about some of them lesion a little bit detailed. So talking about the pulmonary stenosis, so the pulmonary stenosis we already talked about is present in nearly half or more than half of the cases. So as most of you know that the heart is made of 4 chambers, 2 on the right, 2 on the left. The right side has the blood which is oxygen poor, whereas the one on the left has oxygen rich blood come back from the lungs. And there is a wall between the 2 upper chamber and the 2 lower chamber. And then there is a pulmonary valve, which is the valve situated at the entry point of the lung artery, which takes the blood. And as you can see in this video, that the valve, the pulmonary valve is made of 3 leaflets. And these are the 3 leaflets which basically opens and closes at the same time. They work like a one-way traffic controller, allows the blood to flow from one direction to the other direction. The normal pulmonary valves, as you can see, opens very well and all the way, where the kids with the Noonan syndrome can have fibrosis and an obstruction at pulmonary valve, and it doesn't open that well as it should be, and that's where it causes obstruction in the flow. Again, we can see that on the left is a normal pulmonary valve. The flow is quite regular and going easily into the lung artery, where on the one on the right side is stenotic, and you can see quite narrow pulmonary flow. Obviously, it has an impact on the right ventricle because that's a ventricle which is pushing blood across that obstruction. Now, this is what it looks like if you look at in the two-dimensional imaging. Now, pathological specimen exactly looks very similar to what we saw on the video. They are quite thick. The valves are very thick, and some of them don't have a proper 3-valve structure. Basically, it's basically 1 valve, and then there is a space in there. If you compare this with a normal valve, so very nicely you can see 3-valve structure, and then there the valve leaflets are quite thin compared to one present in stenotic pulmonary valve. So you can imagine that how much blood has to struggle to go through those valves. Now, the clinical profile is basically mostly they are mild, which is a good thing, over 60%, which means that they may not need to be done anything about them. And most of the studies have shown that if you start with the mild pulmonary stenosis at the beginning, they actually doesn't worsen with time, and mostly they don't require intervention. However, because we know that there are always some cases on the other side of the spectrum, so they do require ongoing cardiac surveillance or assessment. The moderate pulmonary stenosis, which compose of 10% of the cases, they can worsen over the time, and that's why they need a regular ongoing reviews. Whereas 30% of them are serious, and they definitely need procedure to move forward. It could be valvuloplasty, which is a balloon procedure, or it can be valvectomy, which is a surgical resection of the pulmonary valve. Some cases actually even shows that there is an improvement in the severity. So they start with the mild to moderate, and over a period of time they become mild. It doesn't become normal completely, but they're not causing any significant clinical concern that we need to worry about. So 50% doesn't have any other lesion if it's pulmonary stenosis, whereas 50% do have associated lesion. And then there is a range of defect which can present in kids. So you can have pulmonary stenosis or a ASD, or you can have pulmonary stenosis or a VSD, or you can have a mitral valve abnormality. However, the one which concerns most is the association with hypertrophic cardiomyopathy. So the combination of pulmonary stenosis and hypertrophic cardiomyopathy is something we need more vigilant and we need more closer supervision. Now, talking about atrial septal defects, so as the name suggests, atrial septal defect is the defect in the wall of the atria, and as you can see in this diagram, that there is the right atrium and the left atrium, and then there is a big connection between the 2 chambers. And what it does is causes the blood to flow from left side to come to the right side, and obviously that extra blood goes into the lung and make the child huff and puff. So that's basically because the lung has to work harder for the extra amount of blood it's have to take. Similarly, the ventricular septal defect is the defect into the lower chamber, which we call as the ventricle. So as in the top chamber, there is a quite thick wall in the lower chamber, the right ventricle and the left ventricle, and you can see there is a wall. But when it becomes deficient, that's where we call as a ventricular septal defect, or the hole in the heart, which is a common term. And as we saw in the the atrial septal defect, there is a flow which comes from the left side, which crosses all the way to the right side, and again that extra blood goes into the lung artery, making the child huff and puff and getting tired easily. Now, patent ductus arteriosus is not a condition. It's a normal structure which is present before the birth, and it is required because blood has to bypass from the lung artery to the main body artery, because the lungs are not functioning as when they are fetuses. And as soon as they are born, that duct or the tube, which we can see here, get restricted, and it basically constricts, and over a period of time becomes like a ligament or a fibrotic structure. However, in case it continues to be open after the birth, after a few months, then we call it as a patent ductus arteriosus, and not necessarily we need to do anything about it unless it's a very big size and causing the same problem as ASD and VSD. Now, the mitral valve prolapse, again, is a very uncommon association, but can be present, and you can hear from this sound, is we call as a floppy valve. And what it does is the valve becomes quite floppy, and it allows the blood to go back from the pumping chamber to the collecting chamber, making the heart size to be bigger. And if it's become severe, we need to act on that as well. So we call it as a mitral valve prolapse. And lastly, the branch pulmonary arteries, and you can see in this diagram that this is the main pulmonary artery, and then divides into two. The right pulmonary artery goes to the right lung, the left pulmonary artery goes to the left lung, and then you can see it quite narrow compared to the main body. So obviously, if that's the case, then the lungs are not getting enough blood into the lungs, and the child will struggle over a period of time. And then we have uncommon defects. Some of you may have heard of tetralogy of Fallot, or a common ventricle, or a coarctation of defect, but they're quite uncommon, and they're on the very rare end of the spectrum. Now, when we get a referral and we're asked to see the child with the Noonan syndrome, there is obviously a set pattern we go assessment. The first one is a history, which is quite important, in which we want to know, in addition to whether there is any genetic test confirmation, also how the child is doing, how the feeding is, whether there is any color changes, or how their activity is, whether they get tired while running around or doing exercise. So that becomes an important part. And again, background of the family history with any similar issues in the past. And then the next step is we check for any abnormal heart sounds, whether there is any murmur or any additional click sounds, which do suspect that yes, there is definitely a heart problem, and we need to definitely do further investigation. In terms of cardiac investigation, the most common one are Ecg and echocardiogram. So ECG, as I think most of you may be familiar who've been to cardiology, that it's basically ECG is electrocardiogram. We just note the electrical activity of the heart. So electrical activity starts from the top chamber, goes to the bottom chamber, and then it swirls around the heart. And this is the kind of pattern you see. By looking at it, we can make some sense whether the child have or haven't had any cardiac problem. However, the mainstay of our diagnosis is echocardiogram, or in a simple term is an ultrasound of the heart, which is taking actual images of the heart functioning and see all the walls and the valves and any flow across through them. So this is just a representation of how the echocardiogram looks like. So we have a probe which uses the ultrasound beams, and using the probe in different direction we can see structure. So here you can see the structure we see in the picture is a pulmonary valve, which is we're talking about can become quite stenotic over a period of time. Now there are two images, one on the left is normal, one on the right is abnormal, and you may be able to appreciate that there is a little bit of difference in the flow pattern. The one on the left is quite laminar or a blue flow, whereas the one on the right, which is abnormal, is quite mosaic or a turbulent flow. So this is the one way we get to know how severe the heart condition could be. Now, how do we manage if a child has a pulmonary stenosis? So the commonest one we call as a balloon pulmonary valvotomy. This is an angiographic procedure or a keyhole procedure in which we take a wire through a small entry into the groin, and we won't enter into the groin vein and go all the way to the heart. We put this wire across the pulmonary valve, so you can imagine that the pulmonary valve would be somewhere here. So we put an and then we take a balloon over that wire, and as you can see in this video, that as we inflate the balloon using the saline, it opens up the valve. So, and this is the actual NG of the patient, showing that how narrow the valve is. So that narrowing, you can see hourglass, and then when it opens up, it do a good job. So that's a way. This is a mainstay. So this is always a preferred and the first option if the patient is suitable for this procedure. And it's usually a day procedure. You come in the morning, get this procedure done, and by afternoon or late evening, you can go home. There is no open heart surgery or anything. So, and usually kids recover in very first 24 hours from there. Again, another just which show that from the side that there is this narrowing, and as you balloons up, and you try to open up that valve. Generally, the kids do very well after just one dilatation, but in case there is a reoccurrence, then you can do this procedure in the future as well. If the balloon is not an option, then we have to ask our surgeon friends to actually go into an open heart surgery and open that valve surgically. So you can see in this diagram that this is a stenotic valve. So what the surgeon do, which I feel is quite easy, but they don't think so, is just to cut across the leaflet. So it doesn't look that difficult, isn't it? But yeah, I don't know what they first make. They make all about, yeah. Okay, so the next important problem, which is in terms of severity, this is more severe than the pulmonary stenosis, the hypertrophic cardiomyopathy, which is basically, you can understand from the combination of two words. The cardiomyopathy is the problem of the heart muscle, and hypertrophic when it becomes thick. And in this video, so basically what the hypertrophic cardiomyopathy is, that we know that heart is made of muscles, and we have this muscle on the left, on the right, and when that becomes quite thick, then what it happens is the myocyte or the muscle cell, they become quite thick and rigid, and in addition to all this fibrous meshwork we call as collagen also comes into, and that restricts the ability of heart to function normally. So it causes a couple of things. It obviously reduces the size of the cavity, so you can see that not blood is finding heart compared to the normal heart. On this side, you can see that is really thick and doesn't allow the blood and the heart to relax. So the entry of the blood is quite reduced, but also the exit, or we call it outflow, is also quite impaired. So it causes a devastating effect on the heart muscle and overall heart function. And that's an actual autopsy specimens being taken, one from the normal heart and then one from severe hypertrophic cardiomyopathy kid. You can see how the difference between the two sides. This is the echo to show the difference. So this one's on the left is a normal echocardiogram. You can see the walls are quite thin, moving very well and relaxing and allowing the blood to move freely, whereas on the right side it's quite thick. You can see that how stiff the wall is, and obviously if you have that kind of, you don't expect the heart to function that well. Since I have special interest in MRI, so I put one MRI image in there. So again, it gives a very similar information as the echocardiogram, but just gives in a more three-dimensional. So you can see that the walls are quite thick here and causing obstruction in that area. As you can see, there's a little bit of black flow across it, so that suggests there's obstruction. In addition to that, by MRI has a capacity that you can actually see the fibrosis in the heart muscle. So you can see that on this end, so this is a quite nicely black muscle, which is quite normal muscle, whereas you can see there's a white patch on a child who has a severe hypertrophic cardiomyopathy. And obviously fibrosis is something which impaired the heart contraction and relaxation, but it can also give arrhythmia or abnormal cardiac rhythms. So it's important, if we have something, we do end up doing MRIs more commonly these days. Now, Hypertrophic cardiomyopathy can happen between 15 to 20% of the cases, which means 80% of the kid will not have hypertrophic cardiomyopathy. So that's an important figure to look for. The common genes associated is PTPN11, RF1, and RITR1 genes. And as I already described, it causes outflow tract obstruction, it causes the heart function abnormality, and it can cause arrhythmia, which is abnormal heart rhythm, which means the heart can go quite fast and need to be managed medically. Again, majority of them are mild, over 60% they're mild, which means that we just need to follow them up. We don't actually need to do anything for them. Average case in the mild cases is 4 years, and as 80% do not progress. However, since we don't know which one be 80% and who will be 20%, so we do follow them, all of them, regularly on once or twice yearly basis. However, the one with the severe cases, they actually come into attention quite early, and series has shown that the age of their diagnosis is around 4 to 6 months. And these are the kids who are born with a severe hypertrophic cardiomyopathy and goes into heart failure. And that's why I've been asked to see them early, and we diagnose them earlier. Now, the symptomatic patients who diagnosed in infancy, they actually the one who carry poor prognosis, and they have significant mortality. So the different series has looked at numbers, and they said if the child has severe problem in first year, and they have heart failure, then the mortality is somewhere around 30 to 40%, which is quite high. However, once you go through that phase and the kid survives after that, they have a very good outcome. So that's why we have to be very careful when we're seeing these patients. Now, again, the heart disease prognosis depends on few things, especially on presentation. Age, as I already informed, less than 6 months carry poor prognosis. Severity of lesion, obviously, if the heart condition is more impaired, then the outcome will be bad. And single versus multiple lesions. So if a child only have pulmonary stenosis, has a better outcome compared to a child who has pulmonary stenosis and hypertrophic cardiomyopathy or something else. So as you start adding more lesions, the outcome becomes poorer and poorer. But then we have to see which one is the primary lesion and treat them. So if the pulmonary stenosis is only mild, the child has hypertrophic cardiomyopathy, so the treatment will be focused on that. Whereas someone has just mild hypertrophic cardiomyopathy but has a severe pulmonary stenosis, then we do balloon valvotomy. So we basically tailor our management based on the primary lesion. This is basically a series in which they look for 150 patients, and as you can see, they look at mortality, and most of them were neonates. So basically, if you can avoid bad outcome in the first year of life, then overall the outcome is really good from cardiac perspective. And again, severe was a common factor in all of these patients. How do we manage these patients? So we can do medical management. So we start a medication we call as a beta blocker, which is a common medication a lot of adults take, which used in the coronary or on a patient with myocardial infarction, which slows down the heart rate. And the concept is that if you slow the heart rate down, then you give the heart to have the more time for the blood to come in and pushes out. So that's why you don't want heart to be moving faster than it needs to be. So the beta blocker do help, and also it has seen that it reduces the incidence of abnormal rhythm or arrhythmia. So every patient, if we see has a diagnosis of hypertrophic cardiomyopathy and it's significant, we definitely start them on beta blocker. If the patient does develop heart failure, then we manage them with other medications like diuretics. Surgical intervention, I'll talk about a little bit in detail, and heart transplant, and obviously that's always the final measure if everything fails. If the child is in advanced heart failure or has intractable ventricular arrhythmia, which means that whatever medication you're giving, the rhythms is persistently abnormal, or if you have a severe dysfunction of the heart, then heart transplant can be considered. However, there are a lot of issues with kids looking for, planning for heart failure, because in addition to other things, patient with Noonan syndrome does have problem with lymphatics and other increased risk for other carcinomas while they are on medication for heart transplant. So this is not something we can look at casually. We have to plan it properly and see which patient will be a right candidate. Surgical management. So it's very simple again. As I said, I don't know why the surgeon make fuss about it. It's just chopping off the extra muscle, you know. It's simple, like, you know, you see there's an extra muscle and you chop it off. I mean, how difficult it could be. So this is basically a video showing that the surgeon very simply cut through the sternum, go inside the cavity, put the child on a bypass, make an incision in the main body artery, which we call as aorta, and then look through the aorta, as we will see very soon. And there you go. There's an extra muscle, you know. You just chop it off. You know, simple, see? And you take it off, and then you can see how nicely the heart cavity size is improved, and now the blood is coming nicely in, going out, you know, easy. So, for me, yes, to say, but I'm pretty sure my colleagues won't agree with that. So this is basically a mainstay of a surgical management, and we're still doing it most of the cases who need any surgical management. So looking for clinical guidelines. So the Noonan Syndrome Awareness Association has a wonderful website in which there is a clinical guidelines there on one of the resources, which I think you can follow. And this is basically from Manchester, UK, but I don't think there is any difference in major planning and protocol for what we should do and when we should do. There may be slight difference in different countries and different states, but primarily what it says is that as soon as we get a referral and a diagnosis of Noonan syndrome is made, they need a full cardiac evaluation, which means history, examination, ECG, and echo. They all need to have that at the time of referral or diagnosis. Then once you diagnose, what you do, so between age 1 to 11 years, we see them till age of 3 years or sometimes 5 years, and then make them every 2 or 3 yearly. However, if there is a significant problem like severe hypertrophic cardiomyopathy or severe Pulmonary Stenosis, then we see them more regularly, like once in a year. Once they go to adolescent, again, if it's the first time, then we do an echo and further assessment. If we know this patient is already suffering with a heart condition, then we follow them up throughout the adolescent, and nothing different in adults. So we have adult cardiologist friends who said they have seen patient for the first time and never had any investigation in childhood, just because they were on a very mild spectrum, never been detected, and that was the first time they seen. And usually my feeling is that if they reach to that stage without any intervention, they actually do very well, and most of the time, even if there's a cardiac lesion, it's likely to be a mild in severity. Now, novel therapies, and why are we calling it? Because we are not using them at all here, and they are still in research, but there are a lot of work happening around the world, and it looks quite promising. There are few studies done in US, Canada, and UK, and again, they're used as a last resort measure, but they are quite promising, and my feeling is that in future they will become a mainstay of treatment. I don't know, the time period may take next 10 to 20 years, but they will definitely be there. So one of the most commonly used is Mek inhibitor, which is a mitogen activated protein kinase enzyme. And they've already been used in children and adults for the management of carcinomas, especially the melanomas. However, they haven't been used yet. And we know that vasopathies, but Noonan syndrome is one of them, has mutation in the gene for this particular pathway. So it's quite obvious to imagine that Mek inhibition should be helpful in these lesions as well. So as always, they did some mice studies, and they used trametinib. So they didn't give trametinib to one mouse, and they gave trametinib to another one, and they find a significant difference in their growth, in their capacity for exercise or capacity to move, and also the heart lesion. And these are the findings. They said that it normalizes their growth, the facial and the cardiac defect, and so they can be potentially therapeutic agent for treatment for humans. And taking a cue from that, I could only see one study which has actually used this agent in humans, and this study was done in Quebec, Canada. So what they did is they used it for 2 patients who had early severe onset hypertrophic cardiomyopathy, and they tried all the medical management, didn't work. So they used it as an off-label medication, and it's actually shown that they responded pretty well to that, and both patients were neonate, and the results were quite remarkable. After 3 months of treatment, they were both clinical and cardiac status improved, and even the hypertrophy regressed in both patients, which is something we haven't seen ever before. So with beta blocker or everything we're giving right now, they're only for managing symptoms. So this is the first ever medication which shows that actually the heart muscle mass can also reduce when you use them. So they use it for over 17 months, and then other parameter for heart failure also improved. So this was a big step. And also not just hypertrophic cardiomyopathy, so you can see that even the valvular and the subvalvular obstruction also improved. So there was a significant improvement overall. So there is similar to Noonan's, we have a Lambert syndrome, and then in Lambert syndrome they use another agent we call as an mTOR inhibitor, which actually reverses hypertrophic cardiomyopathy in them. And a rapamycin analog, everolimus, is one of the agents they used, and what they showed in this child was using that medication improved significantly clinical and cardiac feature. However, the hypertrophy wasn't changed, so this is still an agent to look for. However, we don't have that much data to know that it's definitely successful, but definitely it's a symptom did improve for that child. And the last one is mavacamten, and this is a medication which has been getting used quite regularly in adults. So adults who have hypertrophic cardiomyopathy, not the child with, the child who become adult with Noonan syndrome, but hypertrophic cardiomyopathy can happen without Noonan syndrome. So they're actually using this medication into adults, and they've seen that there has quite significant improvement in overall heart function and the cardiac stress. So hopefully, like everything happen in pediatrics, everything comes from the adults. So we get good results from adults, and then we start using them in pediatrics. So hopefully this medication will be tried in pediatric cases, and we may see a similar benefits. So finally, we know that there's a high incidence of cardiac abnormality. Mild disease, generally good prognosis. Infants with severe disease at the highest risk. Mainstay of management currently is still a surgical intervention and anti-cardiac failure medication. However, the result of novel therapies has shown quite good result and promising, and hopefully there will be more studies to confirm and be helpful for use. So that's pretty much it.
Hi, Dr. Gupta. Most of the questions online were about the Mek inhibitors. And I think to summarise most of them, people are asking, do you think the gene therapy or using the Mek inhibitors will become a standard of care for HCM in future?
Yeah, that's a great question, and I think it's hard to say it will become mainstay, but I'm hoping that this will become an important part of overall management. Again, we have a long road to go. We even haven't gone enough adult experience, so I assume that there will be more studies required. So yes, possibly yes, but still we are quite far away from that assessment.
I can answer the question if you want to as well, with other Mek inhibitor trials going on. So for those of you who are very energetic and going to stay for the talks after lunch, which I would advise you to, I'm going to be mentioning Mek inhibitors in the neurodevelopmental talk. At the moment in the hospital, there's Mek inhibitor trials going on for neurofibromatosis, which is another type of rhizopathy, for a type of tumour called the plexiform neurofibroma. So we've got a couple of kids from the rhizopathy clinic in that trial, and it seems to be doing very well. And as I said, there's a mention of Mek inhibitors in neurodevelopmental problems with kids with developmental delay, with some quite promising results. So I think it's an exciting space to watch, but that's a plug for after lunch talks in case you all want to go. The Eagles are playing, don't watch them, they're going to lose. It's too depressing.
Thank you. Thanks, Colin, for that input.
Yeah.
My daughter was born, she got diagnosed straight after she was born with pulmonary stenosis, and they told me that she had a thickened pulmonary valve. So on your picture, it kind of looked like it was a narrowing of the hole. Is that what the thickening would be, or is it different, like from your video, the thickening is different?
It varies. There's a big spectrum. So thickening, dysplastic, and abnormal valve, they're kind of the same. This is a different term for the same thing. So what happened, rather than a very thin parchment membrane-like structure, they become quite thick and fibrosed. Mm-hmm. So they can become quite narrow over a period of time. So I'm pretty sure that probably would be the case.
Yeah, and just with that, they said over time, the last time she was tested was 5. She's 10 now, so she'll be due for another one. But they said it had pretty much gone to normal size, like it had reduced. But they know with kids with Noonan's, it can revert back to get thickened again. Why is that? What is it about kids with Noonan's that it re-thickens?
I mean, it's very rare for that to happen. Generally, once you have a good size valve, they may thicken, but clinically they may not be that important in a long term. They may develop a little bit of stenosis as we go on. Again, it depends on whether the pulmonary valve is able to catch up with the growth for the somatic growth or the growth of the body, because everything is relative. So you may see that the valve is getting bigger, but it's not getting as bigger as the rest of the body is. So in relational term, it may still be small. But again, thickening it's usually we don't see that, they're very common. It will be very, very rare for the valve to become significantly narrow once it has reached to a good size, if that explains.
Hi, up here. Just about can a child have a perfectly fine heart at birth, no indications for like the first year, but then develop like HCM or any other conditions?
So that's a very good question. Generally, we say that if they don't develop hypertrophic cardiomyopathy, they are very less common, but they can. And there are case reports where patients who have been completely fine till 5 years of age, and they came back at 10 years of age, and then they start seeing the hypertrophic cardiomyopathy first appeared on echocardiogram. So okay. Yes, the answer is...
That would show symptoms, would they? Would start to...
And it depends on the severity. Okay. So because the child for 5 years is something, they do activity, they do exercise. So before it becomes severe and something that it becomes quite different, you probably will start seeing symptoms from that. So the kid will start getting tired. There may be some abnormal palpitation. Sometimes they complain of chest pains, and so there will be some indication that yes, there is something going on with the child.
Thank you.
Okay, thanks so much for your time today, Dr. Gupta.
Thank you so much. Yes.